Graduated from the University of Melbourne as a Bachelor of Medicine and Bachelor of Surgery. Gained fellowship of the Royal Australian and New Zealand College of Psychiatrists, along with a Master's in Psychological Medicine from Melbourne University. Completed a Doctorate of Medicine at Melbourne University, and is currently holds positions as a Professor of Psychiatry with Ramsay Healthcare at the University of Melbourne, and is the Clinical Director of Professional Psychiatry Unit at the Alfred Road Clinic, which is where we are today. So he certainly knows something about bipolar disorder. We look forward to some bit of education.
Well, thank you very much. Thanks, it was very kind, and pleasure to be here, and apologies for what I'm sure was my error at the time, so I'm sorry for getting you away. Yes, I did have another talk on my slide set. It was about psoriasis and psychiatry, but I understand you probably don't want to hear about that. My trip over, when I got the call to say, oh, we actually were hoping to start at 7, I tried to speed up a little bit, but then I relaxed, because on the radio, I'll just share this with you because it was kind of funny and it made my trip. On the radio, there was a biologist from UCSD, one of the universities in the States, talking about recent movements in the White House. And he talked about Scaramouche, the media guy, and he said, well, it's kind of amazing really. He came, he bred, he had a baby, he lost his wife, and then he died in 10 days. Kind of like a fruit fly. that kind of made my trip. So look, what I've selected, this is a talk about a few topical issues in bipolar disorder. Some of them are probably more specialised than others, but really what I want to start doing is talking about bipolar disorder, but I really want to hear what you want to hear about. So if at any point during this you think of a question, whether it's got anything to do with what I'm talking about or not, I don't particularly care. I think the main point of this is for you to hopefully get something useful out of me. It may or may not happen, I'll do my best, but please feel free to interrupt, because I think at the end of the day, that's the most useful thing. Just a few disclosures there. We always do disclosures now, and some people want to give me money, that's always good. I guess I called these a few issues in bipolar disorder I'd like to see fixed before I die. I'm hoping that's still the way away, but I don't know what I was thinking when I wrote that. I just kind of thought, these are some things about bipolar disorder that I don't think we understand fully, that I'd really like to see us get sorted out. One of them is the diagnosis, and I'll explain what I mean by that in a minute. Another is this curious idea about mixed states. So when we talk about bipolar disorder, we talk about the highs and lows, but actually that's only a part of the illness. For some people, there's these strange episodes where they have a bit of both at the same time, which kind of does your head in a little bit to think about, in a way, what that must be like. We'll talk a bit about that. We'll talk a bit about substance abuse. You can hardly talk about bipolar disorder without talking about substance abuse of one kind or another. Because if you look at most populations of people with bipolar disorder, rates of substance abuse are the majority, not the minority. Whether it's alcohol, tobacco's in there too, or other drugs, depends a bit on your age. We'll talk about a difficult topic, about premature mortality. It's not an easy topic to talk about, but it is an important one, I think. It goes to physical health, particularly in people with bipolar disorder. Those of you who are sort of familiar with this area realise the lows are part of bipolar disorder, but recently there's been a lot of controversy about how we should treat depression and bipolar disorder. Particularly the idea that maybe we shouldn't use antidepressants, which seems kind of odd, doesn't it? There's this thing called depression and people feel terrible, and we've got this stuff called antidepressants, and we're saying, don't use them? Well, how does that make sense? Let's talk a little bit about that. And I want to talk a little bit about psychotherapy in bipolar disorder, which might surprise you. We don't always talk about things other than medications and so on in bipolar disorder. Where does psychotherapy fit? What might be its uses? And I think there are some different. Let's just talk about the diagnosis of bipolar disorder. Some of you have probably noticed that years ago, when we talked about bipolar disorder, we're probably talking about a group of people who almost always ended up in hospital, most often when their mood was very high. And they'd done things that, in one way or another, landed them in some sort of trouble. So classic mania, as seen in what we now call bipolar 1 disorder. So for many of us, when I first sort of learnt about bipolar disorder, I guess, by working with patients, that was who I would see. And I can remember when I started training in psychiatry at Larundel, not every hospital I work at closes, by the way, just in case you think, but when I worked at Larundel, I can remember seeing people coming into hospital very unwell with mania. Over time we realised that actually they spent more time depressed than manic, probably about 4 times as much time depressed. But actually we didn't see a lot of that because they weren't always in hospital. Only if it got very, very bad. But then in the sort of 90s and noughties, we started to recognise that there was a whole other group of people with bipolar disorder. We now talk about terms like bipolar 2, where the highs tended not to be that dramatic, nowhere near as dramatic. If you lived with a person with them, you'd notice them, but to the outside observer, they weren't so obvious, but they could be very impactful. But that person would also spend a lot of time depressed. That's what we call bipolar 2 now. Some people during that period kind of started to see bipolar everywhere. So when we talk about bipolar disorder, people often use the term mood swings, don't they? Well, it's a useful term, but generally when we're talking about mood swings or different periods of mood disturbance for people with bipolar disorder, we're generally talking about disturbances that last for days. Not always, but generally. And to make the diagnosis, we'd certainly be looking for periods that long, even if there are shorter ones. But the term mood swings kind of entered common talk, didn't it? And so everyone who had, 9 o'clock wasn't so happy, 10 o'clock seemed quite okay, they were having a mood swing. And there was this kind of suggestion that anyone who went up and down, therefore, had some sort of bipolar disorder, which I really don't think was a very useful trend, and I actually think it was quite disrespectful in a way to what the real illness is, to be honest, but it became quite popularised. I mean, according to that definition, and yes, I'm going to say it, if you supported Richmond, you definitely have bipolar disorder. But it got a little bit silly and unhelpful, I think. It led to estimates that 1 in 20 people have bipolar disorder. Now, I kind of have, when I think about new research findings, one of the little checks on what I think about is I think about trying to sell that idea to the members of my family who have nothing to do with health or medicine at all. Telling them 1 out of 20 people's got bipolar disorder, and I think I can picture my dad saying respectfully to me that sounded like a bit of a silly idea. And he would be respectful about it. It seems an awful lot, doesn't it? Just on face value. Using a tighter definition in the Australian Survey of Mental Health and Wellbeing, that national survey we do, the figure still comes out at about 1% of people have probable bipolar 1 disorder. And the best estimates say maybe about the same number again have bipolar 2. 2% still not a rare disorder, that's 1 in 50, but it's not 5%. 1 in 20 people just sounds an awful lot, doesn't it? So probably think 1 in 50 overall. It's interesting, unipolar depression, without any form of mania, we've always known is twice as common in women as men. Even accounting for who presents with problems and all sorts of other influences, bipolar disorder is pretty close to 50-50. And that's interesting. We can probably spend a lot of time on what does that mean. If it's around 1 to 2%. We're talking about 100,000 Australians with bipolar disorder. Which if you think about it as a sort of population level challenge, it's still an enormous number of people, isn't it? We, of course, live in the era where we talk a lot about early intervention in psychiatry. That notion that if we intervene early, we can prevent long-term disability. Good thing, you know. And to whatever extent we can, that's got to be a great thing, doesn't it? The start of that idea was actually with disorders like schizophrenia, where we can predict it's very unusual for schizophrenia to start outside the age range of about 16 to 35. Outside that age range would be pretty rare. Bipolar disorder, the commonest age of onset is still in that bracket, but it's a bit more widespread, a little bit more widespread, which is interesting. So occasionally do we see people with onset of bipolar disorder later in life? We do. One of the questions always is, well, is that because we knew they had depression but we hadn't spotted that they have these milder highs? Sometimes that's true, but sometimes it seems to have a true onset later, which is a very interesting thing. If you look at the prevalence, so this is in each age group of our society, how many people have bipolar disorder? After the age of 55, the number drops. What does that mean? Do they get over it? Actually, sadly, probably the main thing it means is that people with bipolar disorder in Australia do have premature mortality. And as I said, it's a tough thing to talk about, but the figures from a Western Australian study, which is probably the best one I've got, so that people with bipolar disorder, their life expectancy might be reduced compared to everyone else by at least 10 years. That's a lot. Some figures even say more. Most of that is due to physical ill health, which actually says that might be something we can do something about. Not all of it, but most of it. Whereas most of you might think it might be due to other causes, it's due to physical ill health. What can we do about that, about things like smoking, how we manage medicines well, about how some people with bipolar disorder and other mental health problems for that matter find it when they go to see doctors about their physical health, and how are some of their doctors. Some good, some perhaps not so good. As I said, we got some estimates that talk about the frequency of bipolar disorder. The ECA study, it's quite old now, but some of you might know, this was one of the most famous studies of rates of mental health problems in the world. It was done in the US. It said 6% of people, 1 in 16, have bipolar disorder. Extraordinary. Seems extraordinary to me. This was the bit I mentioned earlier, and I'm not sure if we can turn the front lights off because those coloured slides might be just a little bit hard to see with the light reflecting off them. I touched the lights, but something really bad happened. This was a pivotal study that influenced our ideas about... Sorry, I've said a hard task there, apologies. Well, okay, we can see the slides now, that's good. Probably only needed for this slide now. What this study showed, if you look at this pie chart on the left, it followed up a group of people with that bipolar 1 disorder for about 10 years. That's quite a major research effort. What it showed, the purple bit, is that they spent 9% of their life manic. So less than 10%. Like I said, up until that time, we mainly thought that mania was the kind of hallmark of the illness. That's what we often focused on. Now, of course, in 9% of your life, if you're spending money, for example, you can do an awful lot of damage, there's no doubt about it. If you looked at how much of the time they had no symptoms, that was about 50%. Not bad. It's an interesting question with really clear treatment, can we do better? But then when we looked at how much of the time they were depressed, it was over 30%. So as I said, 3 to 4 times as much as they were manic. And suddenly we realised that in treating bipolar disorder well, we really needed to pay attention. We probably can have the lights back on now, it feels a bit kind of spooky or something like that. You've got the principle of the pie charts, I hope. That in treating bipolar disorder well, we really needed to focus more on the depressed phase than we historically had. And that's really been a major shift in our thinking. I'm not sure yet it's resulted in us having perfect treatments for bipolar depression, if I'm honest, but it certainly shifted our focus. This group over here are bipolar 2. So these are the ones just have the minimal highs, not the florid mania. You can see that if you look at time spent well, it's about 46%. 50% of the time, they were depressed. Manic 1% of the time. You can kind of see why this diagnosis is going to be hard sometimes, isn't it? You've got to catch them on the 1 day in 100 or the 1 week in 100 when they're high. And there's a funny thing that happens. When people are high, they don't feel they need to come and see us so much. Go figure. You know, it's a natural kind of thing if you stop and think about it. And because these are milder highs, people are less likely to do dramatic things that are going to bring attention. So many of these people will be treating for quite a long time for depression, and then one day the penny will drop. Hang on, you seem a bit different today. Asking their spouse, have you ever seen this before? Oh yeah, he or she. You know, about once a year they rev up. They're more full of ideas and energy than normal. Don't do anything kind of outrageously outrageous, if I can use that term, but they're definitely different, and I can't get them to slow down. And then it sort of passes. Okay. And I think all psychiatrists would say have had the experience of occasionally only finding it out after they've been seeing someone for quite a few years and going, oh my goodness, oh my goodness.
Can I have a question on,
yeah, please.
On that? You said that those people were traced over 10 years.
Yes.
Most of them would be in treatment at that time?
Yes, it's a very good...
Impacting on that result, surely.
It's a very good question. They were at the onset, but after that it was naturalistic. So some of them stayed in treatment, and probably because they were research volunteer patients, my hunch is they were maybe a little bit more likely to stick with treatment than can happen, you know, in all the circumstances of life. But part of what leads from that question is, well, 50% of time being well, we'd like to do better than that with treatment, wouldn't we? If that's where you're going, it's a perfectly fair comment, I think. The subsequent studies suggest we can do a bit better than that, but I certainly don't want to suggest we're perfect. The truth is, of course, there's enormous variation between people. So for some people, when we find the right treatment that works, for the next 10 years, that whole pie can be yellow. Some people, we find the right treatment, bang. There's other people for whom we really do struggle to find the right treatment, and eventually we'll find the right mixture. So there's a lot of variation within that. It's not like everybody will have the same result, but it's not perfect. I take your point. Yeah, please.
Can I ask, are there specific screening questions that you found useful in terms of assessing for bipolar 2?
Yeah, it's a great question. So if this diagnosis is hard, how do I try to give me the best chance? A couple of things I'd say. The first is, in everyone I see with depression, one of the things I have to think about is, could this person have bipolar disorder that we haven't yet picked up? Now, the people who come to see me with depression have probably already been through a couple of hoops to get there, so they're more likely to be selected that it's not straightforward. That's probably true, but actually I teach to the students who come through my unit that in someone with depression that's not getting better, there's a few things you should always think of, and one of them is bipolar disorder you haven't picked up. In asking someone with depression about mania, of course, if they've already told me, oh look, I was admitted to Larundel, I remember you when you were a boy, Dr. Hopwood, I was admitted to Larundel, and you know, I was full of exuberant ideas, I was going to buy Australia, all that stuff. Well, that's kind of easy, right? The harder ones are, the question goes, look, you've talked to me mainly about lows, and then you've talked to me about periods when you felt well. I wonder if there have ever been periods where for a few days or more, your mood has felt higher than normal, full of energy, maybe had lots of ideas or plans, more than usual, didn't need to sleep, you might have not felt fantastic. You might have felt, and others might have said, you're actually a bit cranky. Now, not everyone who's cranky is manic, just before you accuse me of that, but you might have been a bit more irritable. Might have done some things that are unusual for you, spent a bit more money, and depending how the person who's with me, some way of asking about, you might have done other things that are unusual, you might have felt a bit more frisky or something like that. You know, sometimes finding the right words for that person is a bit of a challenge, isn't it? But it's really asking about the basic symptoms of mania. There's not much point screening for mania. Can involve psychosis with delusions and hallucinations. They're not the ones you're going to miss, because you're going to hear about those. You want to screen for the person who's got subtle mania. Interviewing the partner is really helpful, because sometimes the partner will say, oh yes you do, I know, I remember this, and they'll describe it a bit. The kind of outcome from that, some people have had mild mania and they didn't know they had it. So they can't answer yes. No, they'll just say, no, I don't think I have. And they're being honest. They're not being dishonest about it. They just don't recognise it as such. Some people say, well, you know, I had a bit of that. I think it only lasted a day. I didn't do anything particularly outrageous. You know, no, I don't think I spent more money, but I don't have much money. So sometimes I'll be left thinking, maybe, I'm not sure. One of the things I always do in those circumstances, if I think it could be bipolar disorder, I tell the person. Because I think only time sometimes will tell us for sure. If they at least know I was thinking that, and let's say they see another doctor, then they might say to that doctor, well, actually, he said he thought it might be bipolar, and that might sort of increase the chances of people picking up on it. I think it's important to share, because it does have treatment implications. Please.
You said there were a couple of things you tell your students about depression that seems complex. What were the other?
Well, the other ones, yeah, sorry, left that hanging, didn't I? Well, I think in anyone with depression, look, probably to be honest, you could say this for most mental health problems, please make sure you ask about physical health problems, substance abuse, and anxiety is one of the predisposing things to depression that people often forget about. Many people are depressed when they're depressed or anxious, probably 80% of people when they're depressed or anxious. For some people it's just part of the depression and goes when the depression's treated. For others it's part of the problem that caused them to get depressed in the first place, and unless we address the anxiety we'll miss the point. So I think they're the things I always want people to screen for, because sometimes it's too easy to say, right, you're depressed, bang, we'll do the depression thing and miss a bigger picture. Does that make sense? No. Of course, there are other things that should always be part of a history about other stresses and other things. I don't want to diminish those in any way. All right? The part of the problem then I've been referring to is that we talk about depression and bipolar disorder like we can separate them out easily. Well, part of what I was just saying is, at a single point in time, maybe, maybe not. So there's the person over here who's had, you know, has come out to Larundel, perhaps brought in dramatic circumstances, is euphoric, is shouting hallelujah, which not many people shout hallelujah when they come to see me. It doesn't tend to happen that way. But they're very excited and, you know, full of big ideas. They're fine. That's easy. They've got bipolar disorder. We check that they haven't got a drug-induced problem or something like that, but, you know, pretty confident about that. Over at the far end of the line is the person who's had depression and nothing that looks like mania, nothing. And you follow them for years, never, not looks like it. Then there's a whole bunch of people in the middle. Maybe, I'm not too sure. Some of them will just have had a few days, or maybe after they had treatment for depression for a few days looked a little bit high. On the other side of the line is someone who, yeah, I have had a few periods during my life, a few days only, didn't do anything too over the top, but I'm pretty convinced they were little highs. Then there's people who have periods where they're right in the middle, where they say, for example, I feel terrible, I feel really low. But they'll say it to me, I feel terrible, I feel really low. I've got an idea about going out to buy a car. I think I really don't need to sleep tonight. I'm full of energy, but life is terrible. Right. So they've got that rapid speech and excited and big ideas of mania at the same time as other symptoms of depression. It's quite hard for me to act. I'm probably not very good at acting, full stop, but it's something, when you see it in a patient, it's quite dramatic. This is a mixed state. We need to be careful, because some people, when they're depressed and agitated and anxious, talk quickly about their concerns as well. So we need to separate those two things out a bit. We don't have absolute cut-offs. I suspect I'm not telling most of you something you don't know. I don't have a blood test or an imaging test or a psychological test that can tell me for certain which one of those lumps you're in and whereabouts you are on that line. If only. If I do ever invent it, you'll probably never get to see me again on the yacht in the Bahamas, I suspect. There's some online tests that tell you for certain they can do it. I'm not saying they're all bad, but I don't think they can give you any certainty about these things. It is difficult. It can be really difficult. As I say, sometimes it's not, but it can be difficult. So what are these mixed states? This is another way of representing it. It's kind of useful to think about that. Here's people with depression. Here's people with mania. Here's this mild mania, or hypomania might be a term some of you have heard. It's not a very useful word, hypomania, is it? Does it mean you're not manic, or what? It's a very old word, but it means mild mania. Euthymia means normal mood. Here you are smack in the middle. Some of you may or may not know the derivation of that word. It's from the notion that the thymus was the gland in the body that controlled your mood. Turns out not to be true, but the word stuck. We blamed a few parts of your body for mood disorders. We had to go at the heart, the bile. I think we may have had to go at the female reproductive organs at one stage. Turns out it's your brain, by the way. But nevertheless, euthymia stuck. Then there's these people here who at the same time have bits of both. It's a really puzzling part of the illness. We used to think that it only happened in people who had bipolar disorder for many years. And for some people where it was difficult to treat, they kind of go rapidly and have bits of both happening at the same time, and we're really quite unwell. But actually, this is a Hagop-Ackerscale study following up people in Zurich. And it's a little hard to read. This green bar in the middle represents the percentage of people who had a mixed state as their presenting episode. And it's saying that even in young people presenting with bipolar disorder, maybe up to 40, even a bit more percent, have mixed symptoms at the start. Now, picking ups and downs in the middle of adolescence ain't simple. Some people would say adolescence is a mixed episode. It can be really tricky. You know, rapid mood changes and kind of dramatic swings are kind of part of adolescence, aren't they? So it can be very tricky to pick. I think most people would say the definition they used in this study was a little bit too inclusive to say people were in a mixed state. So for example, if you're manic in every other way but crying, is that enough to say it's a mixed state? I would probably say not. But do you need 2 or 3 symptoms of the other pole to be included? There's quite a bit of debate about that. it's a technical question, but most people would say, well, if you've got a few symptoms of the other pole, we'll say it's mixed. Don't think it's quite that common, but the point is it's common enough and can happen right from the start of the illness, which means we need to be looking for it. I won't go through all the definitions. People have described this for a long, long time though. DSM-5, the latest edition of the American Psychiatric Association's Wonder Book, often gets talked about in the press as the Bible, right? That's blasphemous at some level, I think. I'm not too sure, but I think it's not a correct term. But it's an attempt to try and make psychiatric diagnosis more reliable. It has lots of limits, but it's an attempt. It says you can have mixed states even if we previously didn't know you had bipolar disorder. So it's helpful to pick up those people who've got bipolar but we don't yet know it for sure. I think that's quite important. It says, right? I thought I had the criteria there, I apologise. It says you've got to have 3 symptoms of the opposing pole. So for example, if you're currently depressed, you'd need to have, from the other pole, increased energy, increased goal-directed activity, decreased sleep. Well, that's a bit problematic, isn't it? Because people with depression have decreased sleep too, even though the experience of it is very, very different. Sadness, okay. Yeah, I think I'd be comfortable that's depression. You can see there are some difficult issues. Agitation. Well, people who are depressed can be agitated, and people who are manic can be agitated. I don't want to get too lost. Just to point out, these are important to pick up. We've got growing evidence that if we find these mixed states, it probably does mean our treatment needs to be a little bit different. Generally, they're thought to indicate treatment's going to be a little bit tougher. We also think if there are people with bipolar disorder whom antidepressants can affect the most negatively, it's probably this group. The way I think about it, in bipolar disorder, if you think about us having a kind of choke, for those of you who remember those in cars, on our emotions, that keeps us from getting too high or too low. You could argue it's the choke, that's probably somewhere in the frontal lobe, that's faulty in bipolar disorder. Sometimes it allows you to become too high, sometimes it allows you to become too low. The people who either go high, low, high, low, high, low, or both at the same time must have a really bad choke. That's the way I think of it. I know that's a simplistic metaphor, and therefore antidepressants are really likely to confuse their brain. I know that's a simple way of talking about it, but that's part of the reason why it might be really important to pick up. It's also important because if you experience these, people tell me they feel horrible and they're really weird. And my experience, when by sheer fluke I'm sure I've picked up a couple and said to people, actually, I think what might be happening is this. A couple of them, that kind of acknowledgement that experience, people understand what that is, and an explanation can be incredibly useful. Most of us like to know what's going on with ourselves, don't we? Particularly when we're not feeling right. So I think it's a very useful thing to pick up. Sometimes the truth is picking them up when someone's outside of hospital can be difficult, because you might see them for a short period of time. Probably, if I'm honest, and I don't want to sound, I'm not that clever, probably the times I find it easiest to pick up is when I see someone in hospital, maybe more than once during a day, and hang on, something quite different's going on. I've seen you a few times over a few days. This feels different. What's this about? That can be useful. It's something new that we're learning about, and I expect we'll hear a lot more about over the next few years. I want to talk a bit about comorbidity. I actually put this slide up for 2 reasons. I flagged I was going to talk about comorbidity or the associated problem of substance abuse. But this slide has 2 bits. This is about anxiety disorders in people with bipolar disorder. So this was a study that looked at people with bipolar 1 disorder. That one I talked about before with the sort of fading and florid high episodes and lows. You know, everyone agrees this is bipolar disorder type bipolar disorder. It looked at how frequently does that group of people have anxiety. Now this is not just when they're depressed, because as I said before, in both bipolar and unipolar depression, anxiety is really common. But if you work with enough people with bipolar disorder, one of the things you soon pick up is, for a whole heap, anxiety persists even when their mood's not high or low, and can be a really significant problem in its own right. And these figures back that up. It said 3/4 of people met criteria for an anxiety disorder. 3/4 of people with bipolar disorder. Wow. That seems incredibly high. I must admit, it strikes me as a wee bit high, but okay. And they're of all types. Panic attacks were really common. Really common. This is not just when depressed, at other times. Social phobia was very common. Social anxiety disorder was a term that had a different meaning then, but about 1 in 3 people had social phobia or social anxiety disorder. Very common. Now that can be confusing. Had they become socially withdrawn and anxious because of things that were happened when they were high or low? Sometimes that can certainly happen, can't it? But these are people who also talk about the usual beliefs of social anxiety disorder. Things like obsessive compulsive disorder don't seem quite as elevated in people with bipolar disorder, although they're still more common than in the general population. So when I have made a diagnosis of bipolar disorder, I will always ask people about these things in response to that screening question that might come up. But then if we look at the rates of substance use disorders, actually having said a couple of figures struck me as too high, this one actually strikes me as a bit low. Now, it depends a bit where you work and who you see. If I looked at people with bipolar disorder who were admitted to a public mental health unit, I reckon that rate would be, if not doubled, but would probably be closer to 70%. Have an additional substance use problem that often precipitates the relapse of illness. It's really tough all round. One of the things that's important is the commonest one remains alcohol. So while we always talk about in our conversations about substance abuse generally, about the illicit substances, and that's fine, you know, no one would disagree that ice, for example, is a huge problem in our community, for goodness sake. Problems with alcohol are still far more common. And that's true in people with bipolar disorder. And we know that if you add a substance abuse problem to bipolar disorder's going to be more unstable. It's kind of not a rocket science conclusion, is it? That problems like impulsive action and even self-harm are going to be much higher. And treating the bipolar disorder is going to be a whole lot harder. You know, it kind of intuitively makes sense. And I think often working with, or if one of your family or loved ones has bipolar disorder, this bit can be amongst the hardest to kind of deal with, can't it? Because you can see it making things worse. People often ask, well, what's chicken and what's egg? Does bipolar disorder kind of push people into substance abuse? Or for some people, does their substance abuse bring on the bipolar disorder? We think that substance abuse alone, by and of itself, probably doesn't cause bipolar disorder by itself. But if you have a vulnerability, it can certainly set it off. So the way we think about the cause of bipolar disorder, and this explanation starts with, we don't know everything, okay? There seems to be a significant genetic influence. Now we used to think about genes, so that means you had someone in your family, right? It runs in families. Not that simple. Some diseases, it is that simple, but not bipolar disorder, or even in the genes we know about for depression. It's more like you inherit a gene that increases your risk by, say, 2%. If you have 5 or 6 of those, and nothing else happens in life, no illicit substance abuse, no major trauma, you might get through without expressing the disease. But if a few things happen, that might bring it out. If you've got 20 of those genes, you're probably going to get it. Of course, those other things might bring it on a bit early, but you're probably going to get it. That's more the way we're thinking about it now. In anticipation of the question, no, we can't give you a test that says you've got X risk genes at this stage. There's a few people around who tell you they can. I'd keep my money in my wallet. I don't think with confidence we can at the minute. Maybe one day. But that's the way we think about it. Is it likely the other way around, that dealing with bipolar disorder increases your risk of becoming dependent on substances? Yeah, maybe. I think it's not hard to imagine that, is it? If things are not going well, and then it can really become a cycle of one thing not helping another, very definitely. However, then we've got to think about it in terms of how to help. And this is where we need to really pull away from getting too judgmental about that cause. You've got this problem and that problem. They may be linked in various ways, but we've got to fix them. That's what counts. Getting stuck into you about what's wrong with you, why do you drink, you're not doing the right thing, well, it might have some shock effect, but in the long run, is that probably going to change things? Not most of the time. Does it sometimes propel people into treatment? Oh yes. So if I had people with bipolar disorder or other disorders who've got alcohol dependence, who've come to see me, come into hospital to dry out, and they acknowledge, look, the reason I'm really here, Doc, is I was going to lose my job, my licence, my wife or husband said if I didn't stop, they were going. Undoubtedly, I hear that often. It's good, but it's not that good. Because unless they're really motivated, I'm still not sure that it's going to do the trick. And I know that's a bit tough, but I think that's often the truth. That's no different in bipolar disorder. So we need to say, okay, this is now a problem, we need to deal with this problem. One of the challenges then is, particularly in a public setting, we often separate out their drug and alcohol treatment from their mental health treatment. It's kind of, I don't have any problems being a bit critical of that. It kind of says you can either have one problem or another, when in fact if you've got one problem of any kind in life, guess what, you're more likely to have a second problem, not less likely. It's kind of a bit dumb, isn't it? So that can often mean disjointed treatment, and that's not helpful. In the best settings, it'd be great if they could happen, if not under one roof, at least with good close liaison. I think definitely. And so frequent is the combination, we really should be able to do that. In some ways, I think it's probably fair to say, in a private setting, it's a little bit easier to do that, which is a good thing, actually, I think. But that's not available to everyone. You know, that's great, but it's not available to everyone. I've talked about alcohol, but I don't want to forget about cannabis use. It's not as spectacular in most people's minds as ice or methamphetamine abuse, but it's just as important. Valley did an important study that said 70% of people with bipolar disorder have lifetime cannabis use. Now that can range from, I was at university and everyone was passing it around, and it happened 2 times. Well, that's probably not terribly significant, is it? As long as you didn't inhale, I think is the understanding. But a significant proportion of those people had very significant cannabis use. Very significant. And we know that if you use cannabis and you have bipolar disorder, you're at greater risk of developing psychosis, which from what we know with schizophrenia would make sense, wouldn't it? You sadly are at greater risk of attempting suicide, and you're at greater risk 3 times of having a relapse of your illness. It's bad news. Now, there's a whole other debate about medicinal cannabis, and certainly not my intention tonight to have a big debate about that. But in a way, what that's involved is a sort of softening of the image of cannabis, I think. You could argue, you know, there's lots of angles to it, and I don't want to say, as I say, have a big debate about it. But if you have a major mental health problem like bipolar disorder, cannabis ain't good news. It just isn't. People do it for reasons, and they sometimes find benefits, and it's important in treating this to acknowledge that. But those benefits are temporary, and the medium to long-term effects are not good. The best prognosis you can have if you use cannabis is by stopping it. It's always worth stopping it. I won't talk too much about the neurobiology of that. I thought I'd talk a little bit about ketamine. Now, some of you might have heard about ketamine, this new wonder drug in psychiatry. Ketamine's mainly been talked about in people with unipolar depression. So depression that they never have mania, depression that's not getting better. Ketamine, as some of you know, is an anaesthetic drug, used in anaesthetics. It's kind of frequently discussed in the media as a horse tranquilizer. Well, they actually do use it in human anaesthetics. I think that's probably a little bit unfair when they call it a horse tranquilizer. Somehow that makes it seem a lot worse, right? You'd only give it to Mr. Ed or something, I'm not too sure. It is used in human anaesthetics. It can be a very useful anaesthetic agent. It works on a receptor or a transmitter system in the brain called glutamate. So most of our other drugs seem to work mainly on transmitters in the brain like dopamine, noradrenaline and serotonin. They're called the monoamines. And that pie chart earlier showed us treating those helps us up to a point. So we'd like different things that might help in new ways to increase the amount of time people are well. Glutamate is very widespread in the brain. It's probably the most widespread transmitter in the brain. So it makes sense that if we could manipulate glutamate, it might be helpful. Might be. We've struggled to find things that we can use to do that for various reasons. One of them being, it's a really complicated system. Kind of sounds a bit basic. It is a complicated system, just like we've heard of it. And we've had lots of difficulty finding things that work on glutamate that human beings can tolerate. They actually tend to have a lot of side effects. Ketamine works on glutamate. So, quite a few years ago now, the first trial in the 90s, someone said, well, what about if we give a little bit of ketamine to people with depression? Why did they give a little bit? Well, first of all, they didn't want the risk of making them fully anaesthetised. That's a big deal, right? In anaesthetic doses, some people have a funny reaction to ketamine. It can actually negatively affect mood and cause something a bit like a psychosis. Very transient for some people. So they said, no, we don't want that. But if we give an intravenous dose sub-anaesthetic, and lo and behold, they had some very interesting findings. They did find that if you looked at a whole group of people who'd had several treatments for depression and didn't get better, about 40 to 50% of them had a rapid improvement in mood, like within a few hours. There's not many things we do that improve mood within a few hours, unless you're Barrack for Richmond. I joke, don't want to minimise things anyway. There's not many things that have that sort of rapid effect on mood. With a single dose, the problem is it doesn't last. So by a week, the vast majority of people have returned to where they were before. Some of you might remember a movie, Awakenings, where Robert De Niro played the famous neurologist, Oliver Sacks. It's when they first discovered L-Dopa or Cinnamate, that's the treatment for Parkinson's disease. When they first discovered it, there were a group of people who had a post-viral form of Parkinson's disease, who'd been in hospital in New York for 20 years. They gave them all this medicine, and for a few weeks, they went from being bedridden to up and about. It was the most dramatic thing. After a few weeks, they started to develop horrible side effects. That's a pretty complex kind of moral situation, isn't it? Unanticipated, no one knew that was going to happen. Ketamine's complicated that way. We've currently got trials with ketamine looking at repeated use, and there are a few psychiatrists around who are trialling it. Some of them went way ahead of the pack, and I guess that's doctors vary, don't they, from more conservative to more out there. And there is a version of it that one of the drug companies is looking at for intranasal use. We don't yet know the answer about whether it will be useful. So watch this space. Certainly the College of Psychiatrists has put out a statement, and in it we said, I wrote it so I'm happy to say, in it we said it still should be considered research and not yet a proven treatment for ongoing treatment. Now there's difficult decisions there. Well, if things are bad enough, do I want to try it? Well, it's a complicated decision. As long as you're given appropriate information about what we know about it, that's okay. I worry a little bit if people oversell the latest thing. I think it's really important, if you're ever offered a new treatment, that people say, I'm one of the first people to try it, ask lots of questions. Really ask lots of questions. People have tried ketamine a bit in bipolar depression. You can see, this is the number who had ketamine, 18 in this trial, and the number who had a placebo, which was just a saline injection. This trial's not much bigger. They're pretty small trials. There are a couple of more recent ones. It seems like it has that same effect for some people with bipolar depression. Will we be using it routinely in a few years' time? Don't know. I really don't know at this stage. One of the things I really want to look at too is, over the long term, if you continue to use it, will that cause any problems over longer term use? We should know that with everything we use, shouldn't we? Maybe it'll be a treatment we tend to use in short bursts when people are unwell, and then we'll try and keep them well with other things. Maybe. I don't think we know, and that's important. Why am I bringing this up if there's not that much evidence? To tell you there's not that much evidence. Because if I go out to the blogosphere about bipolar disorder or depression at the minute, everybody's talking about ketamine. Everybody. It's kind of like it's the new whiz thing. So new and exciting was it that there was a clinic opened up, some of you might know, in St Kilda Road, where people could go and get ketamine for treatment-resistant depression. Didn't involve a psychiatrist, and I have to say it's not open anymore. It was also run and financed by the people who run AMS, Australian Medical Services. Some of you may have seen their ads on billboards that I understand assist men of a certain age with certain problems. I don't think that's a commercial activity that, I feel entirely comfortable mixing the two together. I think it was a bit ahead of its time, in other words. We'll watch this space. Right. Just skip past that. Now, premature mortality is a difficult topic to talk about, and in many ways it might be easy to skip over this because, gee, it's, great. Thanks, Dr. Hopwood. I'm thinking of heading home soon and you're going to talk about stuff. Gee, you're a good guy. But we do know, if we look at the numbers in Australia, people with bipolar disorder do die younger than other people. Now, some of you might think of the obvious reasons why that might be, but actually, most of it is not the obvious reason. Most of it is due to poor physical health. So people with bipolar disorder have double the community rate of ischemic heart disease. They have double the community rate of certain types of cancer. And they have more than double the community rate of diabetes. We also know their rates of smoking are way in excess of the rest of the community. So they end up with the metabolic syndrome that you might have heard about, that combination of obesity, hypertension, hypercholesterol, and increased rates of diabetes, and ultimately an increased risk of heart disease. We sort of know that these are problems for our general community, aren't they? We all talk about it, we all look down occasionally and think, yeah, probably should do something about that. When someone's dealing with something with bipolar disorder, that can create more than enough work in its own right, can't it? And the truth is, physical health care is often being pushed to the background a bit. People often think, first off, when we talk about obesity and things like that, about the role of medicines. And there's no doubt that some of the medicines we use can increase weight, I'm not disputing that. Of course, there's a risk-benefit with everything we do. If we're using a medicine, hopefully we found that it's had a benefit, otherwise why are we using it? So that needs to be thought through carefully. The medicines do vary in their tendency to put on weight. So in someone who's already got that problem, we should think about that carefully in our choices. But I think it's important now, thinking about this doesn't stop there. That's where the discussion begins and ends. Well, actually, what about a packet of fags you just finished before you came into the office? The diet, the exercise, the lack of relationship with the regular GP, perhaps the reception you got the last time you had to go to a general hospital. Because we know that that can happen, and that's a real problem too. There's often been a bit of a debate in health circles. Psychiatrists are probably guilty of saying, oh, you know, we touch the soul, not the physical stuff, thank you very much. Well, that's not good enough. And equally, do patients with mental health problems like bipolar disorder find other doctors and other health professionals, I don't want to say just doctors, sometimes aren't as interested in them. Yeah, absolutely. When I was at Larundel, I obviously have fondness for those days in some ways. Not everything about it was good, but I had some fondness. I had a striking experience where a gentleman who was in hospital, he had schizophrenia, and then people stayed in hospital for quite a while. He was a very heavy smoker and overweight. In the middle of the night I got called to the ward, and I'm not a rocket scientist, but I knew he was having a heart attack. I had no doubt about it whatsoever. So we rang the ambulance, and I rang the casualty at the nearest, well, no, it wasn't the nearest hospital actually. I don't want to identify, it actually wasn't the nearest hospital. And it so happened that the doctor in charge of the emergency department was someone I knew. It's a small world, I guess. And I said, we're sending this guy. Oh, okay. Look, we probably wouldn't operate anyway. Well, he's 40, you know, in this day and age. This was a little bit before stenting, but open heart surgery was, for a 40-year-old, was pretty commonplace. Why do you say that? Oh, well, you know, it's all a bit difficult, isn't it? No way. I was quite shocked, and maybe I was a bit naive, it's probably the truth. And do those biases, I'd love to say they never exist anymore, I don't think that's true. And it can happen at all sorts of levels, and if you feel like people aren't going to take me seriously, does that put you off going? Well, I reckon it probably might. So I think that's something we need to work on as well. Alright, let me just move on to the next one. The role of antidepressants. Now you might think, well, this is a bit of a technical thing. Just to explain it a little bit. So there are two different sets of ideas about whether we should use antidepressants in bipolar disorder. And let me just explain what that's about. So, I've said already, a big part of bipolar disorder is depression. People with bipolar 1, 4 times more often depressed than mania. And actually, if you add up what causes their disability over the years, depression causes more disability than mania. Much more. And you know, for people who've had severe depression, that's probably not so hard to understand. Well, if it's depression, then we've got this stuff called antidepressants. And we don't have the perfect answers for bipolar depression. One view is that bipolar depression is just the same as depression. Just get on with it. Use antidepressants, so therefore they should work just as often. The other is, hang on, bipolar disorder is different. Can we assume they work the same as in non-bipolar depression, where we use them all the time? One of the things that used to hold us back, we were worried if we gave you an antidepressant with bipolar disorder, could it push you up into a high? Some of you may have heard discussion of that idea of a switch. Undoubtedly it can happen. The risk was previously estimated as quite high, up to 30 to 70%. It's clearly reduced if you're on a mood stabilising medication at the time, like lithium, sodium valproate, epilim, or lamotrigine. So these days, really we should never be using antidepressants in someone with bipolar disorder without a mood stabilising medication present. How do we get those figures? Actually, they weren't very good studies. They were kind of poorly designed. There's a couple of ways they were poorly designed. One of them is, we know that if you've got bipolar disorder and you've recently had one episode, your chances of having the opposite episode in the next 3 months are much higher than usual. So the question is, how much more often is it if you're depressed and we give you an antidepressant? We don't have a perfect study. We do have studies where we've got thousands of people with depression, some of whom have got bipolar disorder but they don't yet know it. And we can look at, if you give them an antidepressant or a placebo, which ones get a high more often? Which ones switch more often? Actually, it's interesting if you look at those studies, with most antidepressants, switching doesn't look that common. So for the newer antidepressants, the SSRIs, like Prozac, Zoloft and all those guys, it's actually not much different to placebo. Now there might be particular people who are sensitive, that might be true, but it doesn't look that common. With the older antidepressants, the tricyclic antidepressants, particularly in higher doses, it's definitely a thing. And with some of the newer antidepressants, the serotonin noradrenaline reuptake inhibitors, or SNRIs, it seems to be a bit of a thing. Maybe that, like the tricyclics, they act in more than one way and that increases the risk. So if we were going to use an antidepressant, we'd probably try to avoid those if we could. But actually switching may not be that big a problem. A bigger problem, no, I don't have it there. I thought I had the stuff, big part. A bigger problem is, do they work? It'd be good if they worked. So we know in unipolar depression, where you don't have any mania, antidepressants produce a response, that's some improvement in about 60 to 70% of people. Full remission, only in about 40%. There's room for improvement there, isn't there? In bipolar disorder, we've actually now got some good studies that say if you've got bipolar depression, you're on a mood stabiliser, you get depressed, we add an antidepressant, maybe it doesn't work that much more often than placebo. So maybe bipolar depression is different to non-bipolar depression. Now, if you talk to a lot of psychiatrists, they'll say, yeah, but I've got people that I've treated with antidepressants for bipolar depression, and I tell you, they've got better, and that's the only thing that works. Probably sometimes they're right. Sometimes, because it's really hard to sit and do nothing, we start an antidepressant, and maybe the person is going to get better anyway, sometimes. Sometimes they do work, but not as often as we think in bipolar depression. And we also need to be careful of that patient with the mixed state, because we do think they can make things worse then. There's another group who have what we call rapid or ultra-rapid cycling bipolar disorder, where they have lots of highs and lows. The definition used to be 4 episodes in a year, but some people have many more than that. If you have lots of, they're clear highs and clear lows, but if you have lots of them in a year, antidepressants may also make that more unstable. So we'd be more careful there. I just say it's really important because a common response you'll get is depressed, should be on an antidepressant. Because I've heard that the mood stabilisers don't necessarily work as well for depression as they do for mania. Well, that's sort of true. Of the mood stabilisers, we've got the classical ones, we've got lithium, epilum or sodium valproate, lamotrigine, carbamazepine. Lithium is still the gold standard in preventing relapse of bipolar disorder. Full stop. I don't think there's any drug that's proven to be better. It's a bit boring, isn't it? Because it's been around forever, but it was found by an Australian from Melbourne, so that's kind of good. People are very scared of lithium often, I know, but lithium, when it works well, I still feel is the best drug in psychiatry when it works well. It can be really dramatic. It's not for everyone, but when it works well, it can be really dramatic. It's probably a little bit better at preventing mania than depression. Epilim is pretty good at preventing mania, so-so at preventing depression, on average. There are individuals that vary. Lamotrigine or lamictal, much better at preventing depression than mania. So you can see sometimes there's a capacity for a combination there, isn't there? Carbamazepine we used to use regularly, or Tegretol, as it's also known. It's probably fallen a little bit behind those other ones. We tend to use it only now when those other ones haven't worked. That's in preventing episodes. In acute treatment, lithium, epilim can work in treating mania. They take a little while, so generally we'd only use them by themselves if the mania is not too bad. Lithium and lamotrigine probably can work for bipolar depression, but again, they take a little while. So often we add something. Now recently, we use a lot more of what were invented as antipsychotic drugs in the treatment of bipolar disorder, particularly the newer ones, the atypical antipsychotics. We've always used them a fair bit in mania, because when people are very agitated, we'll can't always wait for things like lithium to kick in. And a lot of them have evidence they work in mania. Sometimes we use them in bipolar depression too. But not all of them work in bipolar depression. Only a few of them have got evidence there. Sometimes people stay on them to help prevent episodes. For some people that works. Not all of them seem to prevent episodes either. So a good question to ask is, if you're using this atypical antipsychotic drug for me, it's an important, powerful drug, what can you tell me about the evidence it works for all the bits of bipolar disorder? Because just because it works in schizophrenia, where most of them were invented for, doesn't mean it works for all bits of bipolar disorder. But for many people, each medication adds a bit. So combination medications are not uncommon. That's a pain. It's no point pretending it's a pain. But it is a reality, and it requires continual review, doesn't it, about, well, is this the best combination? What's the benefits? What's the risks? That really should be part of ongoing care. Generally now, for me, my treatment has changed quite a lot in the last 5 years. I would be using less antidepressants in people with bipolar disorder. And just because I'm saying that, I don't want to pretend, therefore the world should change according to Mel. Most of the newer guidelines say the same thing. So we'd be more likely to use a mood stabiliser, plus or minus one of the antipsychotics that works. In severe cases, and I want to stress severe cases, ECT can still be an option. And look, it really can be a dramatically effective treatment, even though I know, people have lots of issues and concerns about ECT. I always think it's a bit unfair that the images you see on television of ECT are all now somewhere about 60 to 70 years old. If someone showed you heart surgery from 60 to 70 years ago, you'd go, that's not relevant to current treatment. I wouldn't think it is. You should think the same about ECT. For another day perhaps, but it's important. So antidepressants, less of an issue now in bipolar disorder. Right, just my last comment, and then we can toss it open for whatever question. A bit about psychotherapy for bipolar disorder. The first thing I want to say is that psychotherapy alone does not have evidence in the treatment of bipolar disorder. I think that's important to say. So there was a phase where people, perhaps going back a few years, would talk about psychotherapeutic treatment by itself of major problems like bipolar disorder, even schizophrenia. I think it's important to say there is not strong evidence that that is good. We do know for both of those illnesses, the more episodes you have that aren't effectively treated, the worse the prognosis, which kind of intuitively makes sense, doesn't it? You'd think that. So one of the things we want to create, I guess, is a greater sense of urgency of let's get on with it, with treatments that we know can work. But psychotherapy can definitely have a role. So we have evidence for a few types of psychotherapy being helpful. If we look first at the prevention of mania, one of the things that has shown the biggest effect in preventing mania is education about the illness, not just for the patient, but for their family as well. Now, there's probably a whole lot of things that does. First of all, it involves everyone and engages them. That's a good thing. Gives them the opportunity to do what you're about to do and bombard me with questions, which is good. It helps everyone recognise what mania is, and sometimes what it isn't. I think when you have illness, it's hard to get your kind of radar right about, now, is this a problem or not? So you can veer between being over-worried, which drives everyone kind of on edge, or not worried enough. Ideally, we like to catch mania before it gets too severe and the person with it absolutely doesn't believe they have a problem. That would clearly be the goal. Can't always achieve that, but that would be the aim. So family psychoeducation, fancy name for talking together and learning about the illness, definitely has been shown to be helpful. Part of that is also talking about the meds. So one of the things that people will occasionally tell me, sometimes they find it hard to talk about, is in my family, someone else thinks that this diagnosis or this treatment is complete, insert whatever word you'd like. That can be really difficult. You know, your loyalties are sort of stretched, aren't they? And usually it's not about people being deliberately mean or difficult. I don't think so. Often it's about understandings and experience. You know, I've never dealt with anything like this before. I don't know. I don't understand. So a big part of psychoeducation can be about saying, actually, this is what it is. Somebody recognises this. All right. And when I talk about it, you might go, oh yeah, right, yeah, we did, actually, yeah, we did see that. And to talk a bit about what the medications are and aren't. There's no doubt that people hold more anxieties about medications in psychiatry than medications anywhere else. We don't have the most toxic medications in the world. I think the oncologists beat us hands down. But funnily enough, people don't ask me many questions about that, do they? They ask some. But it's really interesting. People have lots of thoughts about medications we use in psychiatry. Well, let's talk about it. And family education is, I think, a lot better, as well as with the patient. What about CBT? So CBT fixes everything, right? There's CBT for everything and it's good, and everyone you go and see says they're doing CBT. Everyone. I got into the bus the other day, the driver said, I'm doing CBT. I said, that's good. But I want a ticket. There is a body of literature about cognitive behavioural therapy in bipolar disorder. Basically, the type of cognitive behavioural therapy that's been employed for bipolar depression is more or less similar to what's been used in unipolar depression, focusing on automatic feelings, thoughts and behaviours that either may have led to depression or a part of depression, and if we can undo, are likely to help. There's CBT and maintenance therapy, and often one of the places there, it's really helpful to address anxiety as well. People have tried to develop CBT for mania, but I'm so good, why do I need CBT? You know, so that hasn't gone terribly far. The evidence about CBT for bipolar depression is a bit mixed. There are some studies that say it can be useful. There are others that say no. I think if you look at those studies in some detail, it kind of depends on severity. Surprise, surprise. That just like in unipolar depression, it's not bipolar, no mania, we know as it gets more severe, the chance that psychotherapies are going to work gets lower, and that's often about people's capacity to take in and process what's going on. We're talking about the severe top end here. Bipolar depression can certainly be very severe, and when it's at its most severe, logic says, well, psychotherapy is going to be up against it. In milder forms, it can be helpful. There's also this dilemma that if you've got bipolar disorder, every time you get depressed, is it always part of your bipolar disorder? Because in a way, if you've got the challenges of life, bipolar disorder present, sometimes you might have, if you like, a more reaction type depression to some of the circumstances. You know, it's affected your relationship, for example, something like that. Actually, that makes sense that you might. It can be difficult to pick them apart sometimes, but where it's about a reaction to things, CBT may be particularly helpful. Not all of the studies are positive, but I think it's mainly about severity. We also know that relapse prevention, of course, in bipolar disorder is critical. It's great to get you well, and actually we usually do, and even if we don't, actually usually people do anyway. Most episodes of bipolar disorder, most are eventually self-limiting. Thank goodness. But then the trick is to keep you well. Can psychotherapies have a role in keeping you well? Yes. And can they be mixed in with all sorts of other things like group support, building a structured, meaningful life? All of that stuff is absolutely critical as well, not forgetting your physical health. So I want to kind of say that psychotherapies do have a role in bipolar disorder in combination, and because of the way we run services, that can easily get missed. I think that's true. Particularly in a very busy community mental health clinic, for example. It's important we've got people who are skilled in doing it. And it's important that those people also weave in together well. If they're separate from the person who's managing things when you get really unwell, they need to communicate. So it's not very helpful if this person over here is doing psychotherapy and thinks you're severely depressed, but doesn't actually tell this person over here who might have other tools that could be useful. Now sometimes it might all be done by one person, that makes it simpler I guess, but it's not always like that. There needs to be the capacity to adapt, so the capacity to recognise, hang on, this is really a different kind of problem now. Now's the time to just put a hold to psychotherapy for the minute and we need to move to a different phase. That's again about communication, isn't it? What about the internet? You can get therapy for everything on the internet now, maybe even Barrack for Richmond you can get therapy on that. It's clearly a theme of the night. There are internet-based interventions, kind of CBT in nature, available on the internet. Again, they come with a range of promises. There is lots of evidence for internet-based interventions in milder mental health problems, no question about it. And for many people, they do represent an accessible form of care but it's easy to access these days. Everyone's got a device, haven't they? And also easy to access is it's anonymous, and I feel comfortable that way. We need to be careful about their use where we've got problems like bipolar disorder though. Again, they should be seen as an adjunct to other forms of treatment. I would be concerned if someone with bipolar disorder was relying solely on an internet-based intervention without other professional support. I think there's also accumulating evidence that that internet-based intervention is more likely to be useful if there is clinician support. So they also have the capacity to interact a bit with someone. Even if not directly, they can email a query or stuff like that. Not all of them work that way, but I think for people with bipolar disorder, that evidence is pretty clear. It's tempting to think the internet can fix everything, but by itself, probably not quite. All right, I'm going to stop there. I want to emphasise bipolar disorder, terrible is kind of a bit pessimistic, isn't it? But it is a tough condition. I think we've got to pay that respect. It is one of the top 10 causes of disability in our community, which for not that common a disease means it's tough. So we've got to pay that respect. And this is a tough fact, but I actually think we should talk about it. I know it's tough, but I'd rather talk about it than not. We do know some things about what works and what doesn't, and we do need to apply them consistently well. That tends to be a challenge, doesn't it? And we need to know a lot more. So if any of you have a question that begins with, it seems to me like you don't know all the answers, the answer will be yes. All right. Happy to take questions, and thanks very much for your attention.
Do we want
happy to take chaos, please.
I'll be greedy, you have another.
No, that's good.
Just thinking of personality dimensions and even something like histrionic kind of personality and being depressed at the same time. Do you see that and being different? Like, so
Well, let's talk about bipolar disorder first of all. I think one of the things we need to be really careful of is making too rapid a comment about someone's personality when they're unwell. So for many people, when they're either high or indeed low, even if it's not bipolar low, they can behave in ways that are completely uncharacteristic. So we need to be really careful about making judgments about what sort of person they are at that time. Some people can also behave as a sort of blown up version of themselves. So things, little bits of them that normally aren't a big issue, suddenly get blown up a lot when they're unwell. So we do need to be careful. When a person's well, thinking about their personality is important. Most people think that I mean by that comment, thinking about do they have a disorder of personality, as well as perhaps having something like bipolar disorder. Yes, that, but also not a disorder, but just their personal style. We all have personalities. They range, and that's good. That's what makes life interesting. And Russian novels are built on describing them over 100 pages or more. That's what makes life interesting, isn't it? And our personality, and perhaps those around us too, will influence how we work with illness and how we think about it. So understanding you as a person is an integral part of treating bipolar well. That's why I think with disorders like bipolar disorder, ongoing relationships with clinicians are really important. It takes a while to get to know someone. That's a good thing, otherwise we'd all get married the first date. That probably wouldn't be wise, right? It takes a while to get to know people, and that's true in treating something like bipolar disorder. Building up that trust over time is really important too. So that if you're saying, you think I need to go into hospital, I know you don't usually say that at the drop of a hat, and I trust you to be acting in my best interests. That sort of trust is really important and takes a while. And it's more likely to happen if, I've got a sense of what sort of person and what sort of things are important to you. That's going to vary. Please.
With the health issue, I'm on lithium, and my psychiatrist has told me to split my dose twice, like say breakfast and dinner.
Yep.
But I read a clinical book that said it's better for your kidneys to have it all in one go. So what's your current...
And then you're thinking, oh, that's a bit confusing, isn't it? Thanks very much. The key, there's quite a lot of debate about lithium in the kidneys, and that tends to be the thing that everyone worries about, right? Quite rightly. I'll go through the history of it a little bit, and I will come back. I won't forget your actual question. The original concern came from some studies actually done at the Royal Melbourne Hospital, looking at the kidneys of people who'd been on lithium in the 1960s. Back then, we used to run people, back then I wasn't doing it, just to be clear. Back then, psychiatrists were running people with blood levels a lot higher than we use now. A proportion of those people did show damage to their kidneys long term. Now we know a lot more about the safe range of lithium. A lot more. The evidence pretty clearly suggests if we keep you in that safe range and you never have an episode of toxicity, the risk of damage to your kidneys is extremely low. There's some debate whether there's any at all, but let's just say extremely low. So the key is keeping you in that range. There are two forms of lithium available on the market. Lithium carbonate and Priadel, which is a slower acting version of lithium. It comes in bigger tablets. The normal lithium, lithium carbonate, its half-life is such that to get a smooth blood level, it's 2 times a day. I don't know if that's lithium wrong, but if it's 250 milligram tablets...
Slow release.
Oh, slow release. Well, it's called slow release with the idea being you can take it once a day, because that would be convenient for many people, right? Easier to remember and all that stuff. it actually doesn't quite have a half-life of 24 hours. So actually, to get a smooth level, probably you could argue twice a day is still better. There's some debate about that. That's probably where that difference has come from. Smooth is better for your kidneys, probably better for your bipolar disorder. Now, for most people, if the fluctuation across 24 hours isn't much, it's not a big deal. So if it's working, take it once a day, fine. Proof's in the pudding, it's working, that's fine. And as long as your level doesn't get too high or too low, then it's probably not a big issue for your kidney. Good. No problem. Yeah, please.
You were mentioning before about kind of early adolescence or middle adolescence and that kind of distinguishing between manic episode or just what we all went through in adolescence. And I guess the push more now, mental health is trying to get to the stage where we have more early intervention.
Yes.
And so I'm wondering, let's say for example for parents and that sort of thing, what kind of information do you think you would let them know so they could distinguish the signs between moodiness and early and onset of a manic episode or bipolar depression?
Yeah, it's a very good question. The answer's not a simple or perfect one, but I think one of the hallmarks is generally, obviously we may be talking about more severe symptoms. Thoughts of suicide, but depression, for example, being one of the most worrying, and more prolonged symptoms. So generally, we'd say if something is going on for more than a few days, it should be a trigger to start a conversation. Now, we all know that sometimes that's not easy. I know. Hi, Dad, I've just wondered how you've been going lately. Leave me alone. Tempting not to ask. You're not going to find out if you don't ask, so trying to engage and discuss. Encouraging seeking of help. There's that really tricky balance between encouraging help and pushing and taking over, and then that becomes something that you rebel against. That's tricky, I think, isn't it, for many parents? But severity and sustain. Adolescence going up and down, like the flick of a light switch, for that to be sustained for a long period, that's not so usual. It's not so usual. And I think we've also changed our threshold. We used to say, well, look, I'll wait and I'll wait and I'll wait. Now I think we're much more saying, if you're worried, do something. Don't wait. If it turns out it's not a big deal, hurrah, it's terrific. Better to have found that out than not. I hope that makes sense. Yes. Please.
Think about the overlap between PTSD, particularly agitated depression, for example, and bipolar disorder. Do you think there's, any confusion in diagnosis and so on?
Well, I think it's possible. And acknowledging, first of all, they're not mutually exclusive. So can someone have post-traumatic stress disorder and bipolar disorder? Sure. And most people who have post-traumatic stress disorder for long enough will have periods of depression. Yeah. Almost all. So they can definitely coexist. Sometimes, particularly until you've really got to the nub of it, oh, hang on, I can see there's trauma that's causing some of those symptoms. On the surface, can symptoms of PTSD like anxiety, irritability, cause confusion occasionally? Yes, they can. The trick there is taking your time to take a proper history, building up a situation of trust where the person feels like they can start to talk to you about what the real issue might be. But occasionally at the start they definitely can cause confusion.
I'm thinking with bipolar too, it's much more difficult to
yes.
pick up.
Yeah, no.
Irritability in each
Quite
is
right.
not so discreet.
Yeah, no, I think that's absolutely true. Absolutely true.
Can I ask what you think about meditation?
I was about to say something clever like, I'll think about it for a minute. Look, I think meditation is a good thing. The question is not whether it's a good or bad thing, it's how big is the benefit. So meditation can be extremely useful In many patients with mood disorders. Of course, when they're most unwell, some people just can't do it. Even if they were practiced at it, when they become particularly high or low, they just lose the ability. The evidence that it has a major impact on long-term outcome, there's sort of anecdotal evidence out there. There are people who are real advocates, aren't there, and say it can fix the whole problem. I don't think the evidence overall for that is very strong. So I see it as a very useful adjunct. Some people are suited to it more than others, and then there are clearly different techniques, of course. For some people, it's a really useful adjunct. Other people, it just doesn't work for them. But an adjunct is where I'd see it. Does that make sense? Yeah. Now,
Okay, doctor. I wanted to ask regarding a person I know, very close to me, related, has frequent depression mostly, and then displays anxiety, the hyper-anxiety sort of thing, and panic actually sometimes. And that person is also extremely religious, of obesity as well, and doctor has told that likely can be diabetes as well, and all these sort of symptoms. So could that be linked to bipolar in some way?
Well, look, it's obviously very difficult to tell on a little bit of information, so I'd be extremely cautious about the sort of circus tent diagnosis. It sounds like there are more than enough problems, I must say, and I guess in any circumstance where depression keeps coming back, bipolar is one of the things we should think about, and it's probably worthy of a good assessment. To say for certain whether that's present, I wouldn't venture to suggest, but if depression keeps coming back, is it worthy of getting an appropriate specialist to have a look and a think about it? Sure. Even if it's about, well, what is there that we can do differently in treatment of the depression that might help? Absolutely. And in the presence, we know once physical health problems are present, treatment can be more complicated and tricky as well.
Thanks.
No worries.
Perhaps we just take one last question, because I'm aware you've been on your feet for an hour and a half, and probably a lot more than that.
Probably the exercise is good for me.
Can I ask a question about peer support and social support? We run a meetup group, social support group with about 250 members, and there's other support groups around the area. It makes a massive difference. People come along, whole load of questions, you can tell, self-judgments all over the place. After the first event, they go away feeling accepted, listened to, heard, empowered. Is there more scope for doing such?
Oh, look, I think as a general comment, first of all, that in mental health, embracing peer support has taught us what should be self-evident, that sometimes, if not a lot of the times, a person who's experienced something like you is more likely to be able to convey information to you than someone who hasn't. No doubt. And that feeling of I'm not on my own, other people have experienced this, maybe things about them are different or similar, that's okay. Because many people with mental health problems absolutely feel like they're on their own, 100%. So for all those reasons, a jolly good thing. And for some people, is it a fantastic part of their treatment? Yes. Unreservedly so. Treatment in its own right? Again, I'd see it as adjunctive to the other things, sure, but useful, absolutely. Absolutely. The when, where and how is interesting. So, we've got the presence of peer support workers in inpatient care, in some settings, not all. That can have particular uses. It can mean a different thing in a maintenance phase. But yeah, I think they're a thing here to say, and it's really interesting that the rest of healthcare is starting to wise up a little bit about it. It's interesting, in a funny kind of way, psychiatry has always been accused of being back behind the pack, but on this one, it probably hasn't been. It might have feels like it's probably taken a while, but yeah, very useful. Good question.
Look, on that note, before I thank you, Professor Hopwood, most profusely, by the way, I'd just like to introduce Ray Farrelly. Ray, pop your hand up at the back there. Ray's the Secretary of Bipolar Life, which runs a series of support groups around Melbourne, and Dave, part of that. I think you've got 8 support groups, one of which you operate out of the Mental Health Foundation offices.
Yeah.
So if you've got any questions or you'd like further information about that, please talk to Ray about that.
Yeah.
So I just want to thank you very, very much. I think you've been giving these talks since we were both in short pants and Richmond was winning premierships. Is that a fair sort of comment to make?
Getting close.
Richmond's been in the conversation a fair bit. I really do thank you. Professor Hopwood is a very, very senior and leading professor, not only here in Melbourne, but with a national and international reputation, dare I say it. So for him to give up his time like this is extremely well appreciated, certainly by the Mental Health Foundation, and I'm sure by all of us here present. So very valuable time, and to donate your time, expertise and service, very, very grateful. Now, you have spoken about substance abuse, which is a bit of a problem. So look, I'll pretend I'm a doctor and I'll say, look, this is a medication and I prescribe it probably after a meal 3 times weekly, but any more than that, probably let's
Duly noted, Doc.
Could we give him Professor Hopwood grace us with your presence again next week.
Got it in quick.
I had to get that in. And thank you all very much. We have our monthly seminar sessions on the first Tuesday of each month at 7 o'clock. Please go to the website of the Mental Health Foundation Australia. You'll see our speakers. They're all cutting-edge speakers and a whole host of diverse topics that I'm sure will interest you or your friends, anyone you care to bring. These are free seminars. We don't ask for any payment. This is a public service and all are welcome. So thank you very much.